Welcome to Copenhagen, Denmark. On behalf of the co-hosts of the meeting, World Diabetes Foundation, University of Geneva, East Africa Diabetes Study Group, and the Danish Diabetes and Endocrine Academy, we welcome you. We have been looking very much forward to the meeting, the international meeting on type 1 diabetes, which we are hosting under the title, Advancing a Global Roadmap for Improved and Integrated Care in Low Resource Settings. Today is the pre-conference day. So tomorrow we will have the official opening remarks. But I would like to welcome you all to Copenhagen, to Denmark, to the meeting. This is an international meeting. We have more than 50 countries represented. We have stakeholders from all groups invited and attending. We are here at the IADA Conference Center in Copenhagen, where we will be all 3 days. This is the Congress Hall, where today's side events will take place, consecutive order, starting in a short while. We also have today a separate track for early career researchers. You might have met some of them outside. They will also engage during the day, and of course be fully part of the main program tomorrow and on Thursday. So today is the pre-conference, but it's an equally important part of the entire event. We have a range of a series of 4 side events today, and we will start in a minute. Before that, I wish to say that just outside here, we will have the servings during the day, the lunch and the breaks, and also the evening servings. We have support staff with us here. Anna Tabui and Susanna Jalowska behind there, if you could stand please, from the communications. We also have colleagues with the microphones. They are coming in. There you are. Yes, that's Susanna Tordrup and Sabrina Agboinfi. Can you please say hi? Yes, there you are. And anything you need during the days, please contact my colleagues. With that, again, a warm welcome, and we will move on to the first of the side events. And we could start the next slide. The first side event is entitled Type 1 Diabetes in Humanitarian Settings. Some of you will know that a year ago in Copenhagen we had an international global high-level technical meeting on NCDs in humanitarian settings. Actually not that far from here in the UN building in another part of Copenhagen. I believe we were 300 or more. Those days we discussed NCDs in a broader term in the humanitarian and emergency perspective. Fortunately, that agenda has continued, thanks to many of you. And then when we were planning the side event program, we reached out to our great colleagues in the International Alliance for Diabetes Action, and we would like to welcome you to guide us through the side event. Sylvia, please. And thank you again. Welcome.
Good morning, everyone. It's so nice to see so many familiar faces here. Just to introduce myself, my name is Sylvia Kalenbrink. I am an endocrinologist based in Boston at Brigham and Women's Hospital, and I'm the director of the International Alliance for Diabetes Action, or IADA for short. And I would like to extend my sincere thanks to Bent and the entire organizing committee for giving us this opportunity today to open the pre-conference day and talk about this very challenging issue of managing type 1 diabetes in humanitarian settings. Let's see if this works. Just by way of introduction, for those of you that may not know IADA, it's essentially a collective impact initiative bringing together over 140 organizations globally that are working together to collectively improve diabetes care in humanitarian settings. And I'm happy to share more details in any of the coffee breaks at any point in time. But unfortunately, these numbers every year keep getting worse. From just a year ago here in Copenhagen at the NCD event that the WHO hosted, these numbers have continued to go up. We're facing record-breaking levels of forced displacement globally. These numbers are due to conflict and violence. And you'll see on the bottom the, I don't know if there's a little pointer on this thing, but essentially the green, those are people that are internally displaced, or IDPs, which are the largest proportion of forcibly displaced people globally. And then the blue right above it, those are refugees, people that are displaced and have to cross a country border. The vast majority of these individuals live in lower and middle income countries, and almost 70% are in protracted crises, meaning people are displaced often for decades, and humanitarian providers are having to provide long-term primary care for populations. Now, in addition to the conflict-affected population, there are approximately 200 million people every year that are affected and forcibly displaced due to natural disasters. And there are some estimates currently projecting that by year 2050, there could be 1.2 billion people forcibly displaced due to natural disasters and climate change. This is a huge number. It's going to affect our whole world essentially. And I think we're already seeing the impact of climate change on our world. And the countries, the so-called hotspot countries that are facing very severe ecological threats, the majority are located in sub-Saharan Africa. So, the many countries in that region will be affected. Nonetheless, despite this growing global threat, diabetes is unfortunately not yet a routine inclusion in the humanitarian response. And understandably, many health systems are often unable to maintain diabetes care during humanitarian emergencies. And the types of services provided by different humanitarian actors vary significantly. Even insulin is not routinely provided by organizations. Baseline data are lacking. This is a huge issue. There's very little data in these settings, in low resource settings at baseline. It's often undiagnosed. I think approximately 50% of people, at least with type 2 diabetes, are undiagnosed. And there are no uniform standardized indicators or data collection tools across organizations. I just briefly want to mention the United One study where we brought together 4 humanitarian organizations, the International Committee of the Red Cross, the International Rescue Committee, Médecins Sans Frontières, and UNHCR, to see what type of data are they collecting, what types of services are they providing in terms of diabetes care, and what are the key challenges. And so we did, this was a few years ago, actually, we looked at the data from year 2018 in terms of all of the sites in the world where they're providing medical services. We randomly selected 83 sites across these organizations, stratified by global region, to see, what are they collecting. And so we have data from 27 countries and 5 global regions. And in a nutshell, what that showed was there's no standardized data collection system. Basically, we just document, even within one organization, they might collect data differently from one site to another. And less than half of the sites reported data specific to type 1, type 2 diabetes, or insulin-requiring diabetes, so even that data was not necessarily available, and complications were not routinely monitored. A third of the sites oops, I don't know how I go back. How do I go back? There, okay. About a third of the sites did not provide insulin. And if you look at the top, that shows you like all sites, and then IDP camps, refugee camps. So most refugee camps did actually provide insulin, but IDP camps, only 14% of those camps provided insulin in the cohort that we just talked to. In terms of diagnostics, only 70% even had the ability to check a capillary glucose. And A1C testing, home glucose monitoring, rarely available. So diagnostics are a huge challenge. And as Ben just mentioned, last year we had the opportunity to host a side event here at the meeting that was co-hosted by the WHO and UNHCR on NCDs more broadly in humanitarian settings. And this was a very positive step in the right direction, I think, bringing together all these organizations to start talking about this issue of chronic disease care delivery in these crises. And so, you know, looking ahead later this year with the UN General Assembly coming up, what are our key asks to be included in that meeting, and what are key advocacy statements we would like to make? And so this particular side event, what we'd like to do is outline with a panel of speakers some key critical challenges around providing type 1 diabetes care in humanitarian settings, share some best practices, case studies, and then also, so at the end of the conference, the organizers are planning a 2025 Copenhagen call to action on type 1 diabetes, and also thinking ahead towards the UN General Assembly. And so for us all to think about what are some key messages that we want to share, what might some core asks be that we would like to consider being included in that, if possible. So we're going to now move to our panel discussion, which my colleague Kiran Jobaputra will moderate. He has extensive experience in the humanitarian sector, having worked with MSF for over 16 years. He's currently a consultant for the World Health Organization in their NCDs and humanitarian portfolio. And he's also a strategic advisor to IADA. And so Kiran, I'll call you up to the stage to introduce our wonderful speakers.
All right, thank you, Sylvia. So good morning, everyone. It's a pleasure to be here to join this very critical meeting on type 1 diabetes in low-resource settings. As Sylvia said, the last 3 years I've had the opportunity to work on a cross-departmental initiative in the World Health Organization, linking together the World Health Organization Emergencies Program and the NCD department to look at how we can strengthen NCD integration in preparedness and response to humanitarian emergencies. And just to share maybe 2 or 3 of the lessons that we've learned over the last few years, service disruption from conflict, climate-related natural hazards, forced migration, and pandemics will most likely affect every country in the world in the coming years. And people living with diabetes are particularly vulnerable to interrupted access to care resulting from this service disruption, which itself will result in mortality, disability, and economic impacts affecting whole families. So people living with diabetes need to be considered and prioritized in countries' disaster risk management frameworks and policies. But also, primary health care is the most effective and affordable way to deliver the vast majority of NCD services. And as the recent director of the NCD department in the World Health Organization, who I believe is here today, maintained consistently, primary health care is really at the center of the answer here. And we need to think for diabetes, a great deal of diabetes care can be delivered in primary health care. We know in many countries, the entirety of diabetes care, including for type 1 diabetics, is delivered in primary health care with seamless integration with secondary services when required. And is this something that we can move to? We're already seeing that in many emergency contexts, primary healthcare is actually the most reliable way to continue provision of services for type 1 diabetes in emergencies. And we see that individual countries, individual organizations, and communities have found solutions and put in place measures to keep care going for people living with diabetes in emergencies, and that there is a great deal we can learn from country experience. And hence the panel discussion today. So I would like to invite our panelists one by one to come up onto the stage, meaning that each panelist will make their first contribution, and then I will introduce the next panelist. And I think we will see a diversity of experiences from countries, organizations, and communities of how care has been maintained for people living with diabetes, even in very difficult circumstances. So our first panelist, Dr. Getahun Tagegan, is a consultant internist and endocrinologist and head of Department of Internal Medicine at Addis Ababa University's College of Health Sciences. He is also a founding member of the Society of Endocrinology and Metabolism of Ethiopia and is the president of the Ethiopian Diabetes Association, significantly contributing to the improvement of diabetes care and policy in Ethiopia, especially type 1 diabetes. Doctor, please join us on the stage. So Dr. Getahun, you have diverse experience of leading service delivery for diabetes during periods of service disruption. I know particularly during the COVID pandemic and beyond. So I'd like to ask you to provide your intervention for 5 minutes, highlighting how can we ensure continuity for people with type 1 diabetes in these circumstances. Thank you.
Hello. Hello, can you hear me? Can you hear me? Okay, yeah. Thank you. First of all, I would like to thank IADA and World Diabetes Foundation to invite me in this very, very critical discussion, which is very applicable for the countries that I came from, because we have been involved in pandemics, conflicts, and all the things, and we have seen the worst impact of having a conflict, especially in the care of type 1 diabetes. So I came from Ethiopia. Ethiopia is a country in Eastern Africa with a population of around 130 million. And greater than 150 kids are expected to have type 1 diabetes, though we don't have a strong registry. And I also chair the Ethiopian Diabetes Association, which has been working for the past 40 years, serving patients with type 1 diabetes, specifically type 1 diabetes. And we have around 20,000 kids under our support in like 90 branches now. We have reached, during the COVID pandemic, we were 60, and now we have reached 90 branches. So by the first time we heard the first case of COVID was diagnosed in Ethiopia, everybody was shocked, actually, including all the physicians, the doctors, and all the community. But the worst impact came for patients with type 1 diabetes, because, and then immediately shortly after the COVID, the conflict in the northern region came, and the impact was actually continuity. So what happened to the care to type 1 diabetes is there was a total disruption of routine care. That's a reduced supply. We used to supply insulin, glucometers, and other materials like for monitoring for around 20 kids in 60 branches then. Now we have reached to 90, as I said. So all these things were disrupted immediately. And the supply chain, even from the ministry, was actually in challenge. And there was great stress, which makes type 1 diabetes care difficult, because patients were isolated, they were in a severe emotional stress, they couldn't take their medications and their monitoring, they couldn't access health care facilities, and there were repeated calls of complications that occurred during the pandemic. And you know that diabetes is one of the poor prognostic factors for diabetes, and that was a great worry, and of course we have seen many casualties even then. So that was a very stressful situation for us in the Ethiopian Diabetes Association. And also there were an increased diagnosis of diabetes due to COVID, which tends to be worse clinically. And these were the situations that we face, because our supplies were for a limited period, and that was suddenly disrupted, and that caused scarcity to insulin. And these were the few challenges that we had, and that we did, though we didn't completely address all the issues, was the first thing was to be involved in telemedicine, what I did was I also used to work in the university. Immediately there was a shock for everybody, but later we assigned physicians, including myself. I was the head of the department of endocrinology then. And what we started doing was a telemedicine. We are just giving the numbers. We call a limited number of patients every day. Every physician calls every patient on the list. And we were adjusting the dose of insulin that they had. We are detecting complications. We are seeing, especially diabetic foot was a very serious issue, those who had it. And we are sharing pictures amongst ourselves from the patients. And then we somehow reached some people. And there we arranged home visit from the Ethiopian Diabetes Association. We formed a WhatsApp and a Telegram group for patients. They can share their information, they can ask us online, and we tried to share some of them. And we were involved in mass media continuously, including myself and all my colleagues. We are just trying to address all the issues related to diabetes and COVID, what the precautions should be taken, dose adjustment, and everything was being made. And later, because there was a scarcity of insulin, we organized a group to deliver insulin to the periphery also. But still, we couldn't reach all of them. That was a great challenge, but we arranged to give at least in the nearest places in the regions or in the counties, whatever you say. And the other problem that we had was those people who received insulin from us were economically underprivileged, most of them. And the issue of even feeding was a problem then. And we were also, we tried to, it was good if I brought some pictures. We provided like some materials to eat, like what's that called, flours and things that are immediately eatable for those who are underprivileged. And this was done in almost all the centers that we had. And the other thing that we did was when the vaccination started, we used to give, this is for type 2 diabetes specifically, we give to special preference or special privilege for those patients who are registered as diabetic. And if they are sick, we were facilitating their early admission to the hospitals because all the hospitals were congested. So this is the things that we did during the pandemic. And immediately after this, the conflict in the northern region came, where the northern region was totally decapitated from the center. And unfortunately, we had the greatest number of type 1 diabetes in those regions. And we were the ones to supply insulin. And then there was a great problem of delivering insulin. And finally, after so many communications, we arranged to deliver insulin through the ICRC to those regions. But I admit there were many casualties even there during that conflict. And there are still problems. That's why I said this issue is very critical. Even now, we have problems of delivering insulin to some of the regions, and especially in those regions where the supply from the government, which are very remote areas with type 1 diabetes. And this is experience that we had. And if I have time, some of the recommendations from our experience, telemedicine should be strengthened always, because in case of emergencies, that helps. And healthcare system resilience is very important. That's very, very important. That's what I see. We should involve the communities. We have enormous resource in the communities in such disasters, which can help in delivery, in improving and in psychosocial support of patients with type 1 diabetes. And again, a multidisciplinary and multi-organizational approach is very, very important in addressing such crises, which are usually unpredictable. And the supply chain system should be strengthened always. And always, as I said, health inequities should be addressed, because they are the victims to be the most vulnerable victims during pandemics and emergencies. So equities are very, very important. And this is part of the experience that I had. Thank you.
Thank you very much, Dr. Getton. I think there's so many things there to follow up on. Thank you for highlighting the diversity of challenges and the diversity of the solutions that are needed to ensure continuity in humanitarian settings. There will be time for questions, but we'll run through the panelists' contributions first, if that's okay. So let me invite Stéphane Besançon to the stage. Stéphane is a biologist and nutritionist, specializing in nutritional physiopathology and international development. He's the founder and the CEO of Santé Diabète. He has led pioneering initiatives to improve diabetes prevention and care in Africa. His work on health systems, chronic diseases, and access to treatment has been widely published, and he has contributed to key reports for government and international organizations. So Stefan, likewise, please take 5 minutes to talk us through some of the experiences and messages you can share, and particularly highlighting how I know your organization has had experience in severe acute crisis with complete interruption of supply chains. So what can be done in these situations for people with type 1 diabetes?
Thank you, Kieran. Yes, we are working in a lot of countries with a lot of crises, and Mali is in chronic crisis in 15 years, but this one. Okay. And I focus this presentation on 2012 because it was not chronic crisis, but the acute, very, very acute crisis phases. Just to give you a little context and to understand why we're speaking about acute crises, in some weeks, there is a lot of event. In 3 weeks, there was a coup in March 2012, and followed by the occupation of the North region by the terrorist group, and the war began in some months ago. And you can see on the map, it's for that I put the map, the country was totally cut in 2 parts. The north with war, occupation, and whole the system and collapse, no more possibility of communication. And the south, it was not a total collapse, but there is a lot of problem because there is coup, no more government, and everything. But the important thing and the acute thing was for the north of the country, but it's huge part of the country with total lack of health human resources, no possibility to have a laboratory, no access to drugs, and for patient a lot of problem. And we was on the field. We not our humanitarian organization specialized on acute response, but we had this situation, and in 1 week we decided to develop a response because we have a lot of patients, type 2 and type 1, in this global area without nothing. So I will describe rapidly what we decided to do and what we did. The first thing, in the main city in Timbuktu and Gao, we organized the evacuation of the type 1 diabetic patient who have access and the possibility to be evacuated, because in this context it's not easy to evacuate patients. And for other patients, for type 2 and type 1 patients who are not in this area and with the possibility to be evacuated because they was in the district or totally in the bush, we organized a total providing of insulin, syringes, strips, and all needed with providing every quarter to be sure, and for type 1 to be sure that they have continuous availability of insulin. And it was a huge challenge because in this type of country like Mali, there is no registry of patients, so and the communication was almost totally done, so it was very complicated to know where was the patient. So we decided to work with the patient association and to provide every quarter all we need, insulin, strips, at the patient association. And after the patient association, we have contact with the patient in different area. We provide more than 25 patient association locally. They provide at the patient of the need. And we use also a little bit, there was some doctor with stay on the field. In this huge area, there's less than 10 doctors stay on the field, and we use it also to provide insulin, strips, syringes, and everything for the patient. It's acute phases. In 2 weeks, there was nothing on the field. So it's not management, it's providing, it's life-saving support. It's important to say that. So it was to give to the patients that they need, And in totally, we support 1,800 patients, including 50 patients with type 1 during the 3 years, the time that the system will come on. And other thing, very quickly, we had information with a lot for type 1 diabetic patient, DKA, without system to manage the DKA, so we developed some kits, but it was not a very technocratic thing, just a box, and we put what we can in the box and we send it on the field. But that's work. A lot of doctor on NGO doctor, UN agency doctor was on the field, or other type of doctor use it and save life with that. And this kit, this box, was the beginning of the discussion with Slim Slama and to work on the WHO emergency kit because at this time, it was not something very robust. It was we took what we can and we put it in the box and we send it on the field to be sure that people have something. So it's our experience. We did that during 3 years, and after we changed the model because there was a rebuilding of the health system with the chronic crisis, and we changed. But I think other people will speak about chronic crisis, that it was our experience in acute phases when the system go down in 2 weeks and we need to provide everything because for type 1 diabetic patient, if we did not provide insulin, syringes, etc., all the patients die. And we lost just 2 patients on more than 100 patients. So it was not perfect because it was not provide care, it was just provide supply, but that saved life of patients during these very hard acute phases. And if you are interested, you can see all the response on this paper in Conflict and Health. That's my point. Thank you.
Thank you, Stefan. So it's okay. Yeah, an exceptional situation, but unfortunately not entirely exceptional. So I think those lessons have been have applied since then to multiple other settings. Philippa, if I can invite Dr. Philippa Bull as our next panelist. Philippa is the Non-Communicable Diseases Advisor and leader for the Chronic Conditions team in MSF Switzerland and leads the MSF International Working Group on NCDs. She publishes and lectures on non-communicable diseases in humanitarian settings. She was previously the medical responsible person for an operational team in MSF Switzerland, overseeing MSF's work in Africa, the Middle East, and Central America. And she has worked with various MSF projects in clinical and coordination roles in diverse settings. So Philippa, from that extensive background in multiple different emergency contexts, particularly protracted crisis, but also acute crisis, what have we learned about sustaining care for type 1 diabetes in lower resource settings?
Thank you, Kieran. So I don't know what my slides are doing. Oh, that's not really working. So hi, everyone. Hopefully the rest work better. So just for those of you who don't know MSF, MSF is an international medical humanitarian organisation that provides medical care to populations in distress and victims of conflict or catastrophes all over the world. And over the last decade or more, provision of diabetes and other NCD care has been an increasingly important part of the care that we provide in acute as well as protracted crises. And over that time, we've gained significant experiences in the huge challenges, but as well the various solutions for provision of care in some of the most difficult places of the world to live with type 1 diabetes. And so I want to share a few of the lessons that we've learned, particularly from protracted crisis settings, where we've been able to sort of trial and adapt models of care. But also, and some of these are really relevant, I have to say, to sort of broader, low resource settings. But of course, there are also important lessons from acute crises. And I think the first message, which I hope is not anything new to anyone in the room, is that provision of insulin in an emergency is an emergency. However, the provision of insulin alone is not enough. And too often in places we work, we've seen that there's really an absence of the injecting supplies needed to go with that insulin, and a really glaring, almost routine absence of provision of glucose monitoring and strips to those needing to inject insulin. In the middle of a crisis with disruption of healthcare access, altered daily routines, sorry, the slides seem to be having a mind of their own, lack of access to regular food supplies, I think that was already mentioned, and we certainly see that in many of our settings. People needing to sometimes switch insulin to whatever is available, stress. The ability of people to monitor their blood sugar is a critical safety issue and potentially a life-threatening one. The second important lesson we've learnt, and I think this is becoming more widely known, but the lack of refrigeration should not be a barrier to provision of insulin to people needing to use it. There's increasing evidence on the thermostability of insulin, and MSF has provided insulin to people living with diabetes in multiple hot settings in the absence of refrigeration, often stored in locally made cooling containers like the clay pot seen here. And through this, we've seen dramatic decreases in acute presentations to hospital, but importantly, improvements in people's quality of life with the ability to return to employment and schooling and the chance for improved outcomes overall. But then lastly, regarding insulin, injecting insulin via a vial syringe contains significant risks and challenges, particularly in humanitarian and low-resource settings. And pens are preferred by patients and can be safer, but also they should be a lot cheaper than they are. I don't know what this is doing. And we've done some studies around the pricing for pens and shown really they could be provided for $1 a pen. And so thirdly, one of the important lessons that I wanted to share today is really that this management of type 1 diabetes is feasible at primary healthcare level. We've done it in low resource and humanitarian settings using general doctors, clinical officers and nurses who task share the roles between them, of course supported potentially by telemedicine, also mentioned already, with a good system of training and support. And this has enabled us to provide life-sustaining care to children and adults with diabetes in remote places where otherwise they may have had no access to insulin. Fourthly, the role of people living with diabetes is critical. We've always included patient education as an indispensable component of management. And of course, anyone living with diabetes needs to be able to self-manage, but this becomes even more important in fragile settings where access to ongoing quality care is not assured. We're working to further improve this empowerment, including peer support groups and patient advocacy training, as well as deeper involvement of those living with diabetes and other NCDs in the care design, provision, and adaptation of care. I'm really sorry, this slide. And lastly, we've seen the importance of resilient healthcare, I think also mentioned by my colleague, that's able to adapt to crises. So a very recent example was the setting of Lebanon, where we've been providing care for people living with diabetes for 13 years. And the teams in this case had prepared for an acute deterioration of the context, and this really paid important dividends when Lebanon was under Israeli bombardment last year, where teams had pre-planned the supply systems and planned the adaptation of care in the event of disruption. So they were able to supply multiple months of medication to patients. They switched to the use of teleconsultations for displaced staff and patients. And they had pre-existing peer support groups, and they became really important. They were sources of support for each other. When patients were under acute bombardment, they were able to send representatives of the peer group to source medication from MSF. And even in the really acute situation, they were able to share insulin between them when there were absolutely no other options. There was an existing WhatsApp group for type 1 diabetes patients with MSF staff moderation, and that was extended to the whole cohort and used to share patient education materials, to answer specific questions, and to receive and distribute information on insulin and other supply availability. So in conclusion, from the MSF experience, responding to diabetes in emergencies requires recognition of its life-saving importance, urgent provision of this bundle of insulin injection supplies and glucose monitoring, preparation for care disruption with sustainable, adaptable supply systems and adaptable patient care, and facilitation of the empowerment and connection of, for and between people living with diabetes.
Thank you very much, Philippa. Once again, a lot of content in that short intervention. Just to warn the panelists, at the end, I'm going to ask you to select one key message from all of those, so just prepare yourselves for that. I just want to highlight, because it has been this issue that Philippa mentioned about the provision of insulin without the means to test glucose. We have seen this in a number of settings, and Stefan mentioned the WHO NCD kit, and our colleague Slim Slammer, who was very much behind the development of that kit. We are reflecting on how to ensure the modules of the kit are set up in a way that facilitates ordering to ensure that the testing equipment matches the insulin, and we have developed procurement guidance now to support the users of the kit to ensure that procurement of quantities of insulin and diagnostics can be harmonized. But this is just a small piece of the puzzle, because I think this issue extends well beyond the provision of any single kit. I'd like to invite our next panelist, Sana Ajmal, up onto the stage now. Sana is a global diabetes advocate and the executive director, apologies, Sana, if I mispronounce this, of Miti Sindagi, a pioneering initiative for Pakistan's type 1 diabetes community. Living with type 1 diabetes herself, she has transformed care through innovative distributed delivery models, reaching 93 or more cities. She's a commissioner for the Lancet Commission on Type 1 Diabetes. She co-authored the ISPAD guidelines of 2022 and serves as publications lead for Parliamentarians for Diabetes Global Network. In recognition of this work, she received the Leonard Thompson Award in 2021. So Sana, thank you. We're lucky to have you with us. Your work in Pakistan has highlighted that there is a lot of resilience within the communities themselves. So from your experience, how can you work with the community to mobilize resources and make sure that people are safe?
Can you hear me? Yeah. Okay. Thank you, first of all, Kieran, for inviting me here, and to IADA and to the organizers of this meeting, World Diabetes Foundation, for shedding light on this very important subject. First of all, I would like to reflect on, very quickly on what Philippa said, and I'm very glad, because that seems like an advocacy win, because I've been shedding light on the resilience of communities for quite some time now, and MSF using that model is not only encouraging, but also seeing the results, and I'll show you how we do it. So Miti Zindagi basically works just for type 1 diabetes in Pakistan, and we have a 5-pillar model where we work on these 5 key areas, which include access to medication and supplies, access to adequate treatment, empowering education, emotional well-being and peer support, and enabling policy and social environment. I have a COI disclosure to make. We received around 4% of our annual funding from pharma in 2023 and 2024. Peer support is at the heart of everything we do, because we truly believe that if we have to ensure great lives with diabetes, we have to trust in the communities. There's a top and a bottom. We're making a system, we're developing systems, we're developing policy, but then what happens on grounds might be radically different from what we are looking at, how we're looking at things sitting in an office, in a headquarter. So the communities really need to be engaged in any response that we want to deliver. In 2022, around 1/3 of our country was underwater. 33 million people were affected. You can see this map here, depending on the scale of where the devastation was the most. And as you might be able to see, this area on the bottom right, Sindh, was the major affected area. Now, this is a huge desert, and a desert with very little road access. Similarly, in Balochistan is a very barren area where there is very little road access. the major challenge that we were facing was, how do we even deliver insulin there? We wanted to do something, and the community was very affected. I mean, people were coming to our office saying, what can we do about it? Can we go there? Can you send us there? Can we do something about it? People wanted to help, but we couldn't find initially the way to go there. We tried contacting every big relief organization in the country, every big relief organization that was working on ground. They were so overwhelmed with the scale of the catastrophe, with the scale of outbreak of infectious disease. Diabetes was not on their agenda. And type 1 diabetes, they probably did not even understand what type 1 diabetes is and how to carry insulin. Oh my God, the responses we got was, oh my God, but who will take care of the logistics? Who will take care of the cold chain? There were so many things that they were actually overwhelmed with and did not have the capacity to commit to at the moment. So what happened was that our community members, they decided to take it upon themselves. They went from camp to camp, they went from village to village, went to the mosques, started announcing there that we are ready to bring you insulin to identify people with type 1 diabetes, children with type 1 diabetes who were affected. We had to carry insulin in boats. There were our community members who carried insulin on foot through this desert, wherever they could. And this is what, I'm sorry, I'll just go back one slide. How do you go back? Okay. And this is how our community actually made sure that to the scale that we could in that first trial, we delivered the insulin to the people who actually needed them. We ended up supporting 300 children with type 1 diabetes through this effort. Now, having said that, I do think, as I said earlier, and Philippa has been mentioning as well, that the existence of a peer support community at the ground level makes a lot of difference. They are your information sources. They're also your first responders, because when people know each other in a certain area which is affected, they might be able to help each other. They might be able to get that information to you. They might be able to share insulin or share test strips or bring you supplies when they're bringing it for themselves. So now, learning from this, what we're trying to do is that we are building a buddy support system throughout the country, where our community members who are capable or who have the resources to go to smaller areas and talk to people, meet them. We're trying to create the small community groups everywhere where we can access. We're going to people's homes to try to understand what their lives are like, picking out from within those groups people who might be able to lead a community group in that area to make sure that next time a catastrophe happens, we don't have to wait for a month or so to try to understand what we can do and have that information available. I'll just read out this heart-moving note from Anam when she went to the first child's home to just meet her and see what life is like for her. She wrote, came back to her home and she wrote, fear of touching the age of 22 or the needles, how to gauge which one is bigger. No electricity greeted me when I reached her home, yet her radiant smile lit up the space. She was a bundle of joy, a spark of light despite the heavy shadows around her. But beneath that joy lay a reality that shook me to my core. In just 2 more years, when she turns 22, her access to life-saving insulin will end, leaving her racing against time to build a future that can sustain her. She learned to cook, apply henna, do makeup, style hair, and do much more. With a dream to become a teacher for now, her most urgent goal is to take a computer course. Why? Because earning from home might be her only way to survive. The makeup and styling services aren't enough because those around her want them for free or at bare minimum rates. She believes that with her computer skills, she could earn to sustain a life. Her mother, grateful to Meethi Zindagi for providing insulin, asked questions that exposed painful truths. What happens when she turns 22? If she gets married, the family will most likely be of a similar socioeconomic status. So after 22, when the insulin support stops, then what? These words left me speechless. Life is already an uphill climb. With type 1 diabetes, even the smallest dreams like taking a course or having a steady access to insulin becomes insurmountable challenges. Humanitarian settings do occur in emergency, but humanitarian settings exist amongst us day in and day out. And my last thing, because I wanted to end on a happy note after this very sad intervention, is that after our home-to-home deliveries of insulin, which we carry out across Pakistan at the moment, we are trying to take peer support near everyone's homes. And I wanted you to meet the buddy that has been assigned to me, this 4-year-old child, who has relocated from another place to, oh, I think we don't have the sound. It's just me. He has relocated from another area, which was struck by a disaster. And I'm sorry, this doesn't sound the same without the sound. I'll say thank you to Gavin for this beautiful idea of team insulin versus team carbs. It works every time. Because insulin alone, even in a humanitarian setting, is not enough. We all need our community. We need children to not just survive during that crisis. We need children to thrive and become useful members of the society, mentally healthy as well as physically healthy members of the society to continue to actually, be healthy and productive. That's all for me. Thank you.
Sana, thank you very much for what in fact was also a great message of hope at the end, and I think particularly for highlighting the role of community and broader solidarity for addressing these challenges of care for people living with diabetes. That's a message we need, particularly at this time. So thank you very much. I would like to invite now our last panelist up onto the stage, Dr. Mahmoud Dawat, who is the Global Non-Communicable Diseases Officer at the International Federation of Red Cross and Red Crescent Societies in Geneva. I'm always amazed that for that huge international movement, there's just one person who has that role at headquarters. So I always think he must be very worn out with all that work. But Mahmoud is a psychiatrist and a public health professional with a master's degree in international public health. He works to strengthen and support the capacity of 191 Red Cross and Red Crescent national societies addressing NCDs and related health challenges. So I think in the last few panel presentations, we've seen how challenging it is to rapidly respond to ensure people living with type 1 diabetes have care in the context of crisis. What can be done, Mahmoud, to ensure that NCD care is resilient to crisis and therefore to reduce the risk of crisis for people living with diabetes?
Thank you, Kiran. I would like to thank the co-host for this high-level meeting and also for IADA for organizing this side event. Actually, for the International Federation of Red Cross Red Crescent, as you had mentioned, we are supporting 191 Red Cross Red Crescent national societies, which means that by the mandate of the Red Cross Red Crescent, that we are auxiliary to the governments. That means that we are transmitting and translating what have been discussed at the global level into local actions and in advancing the localization agenda on the ground. We're relying on 16 million volunteers who are working on the ground. And based on this, I foresee, as we are discussing now, this type 1 diabetes, one of the most neglected people are living at the humanitarian settings. And based on this, I foresee last year have been launched the NCD vision and framework for 2030, where we are envision a world for 2030 that we have universal NCD coverage for everyone, everywhere, in all settings, especially in humanitarian crisis. Linking this to the resilience and also how we are acting as auxiliary to the government, where if we know about what called the disaster risk reduction and disaster response law, that's meaning that's how we are enforcing the development of this collaboration with the government and developing institutional frameworks and utilizing the emergency preparedness response tools and mechanisms. Based on this, I foresee have emergency preparedness tools, which is empowering the national society to work with the local actors and see how we are doing an early warning system. So that's for in terms of preparedness. But the thing that's unfortunate, we are lacking the integration of NCD, and we are looking for type 1 diabetes. We're lacking that integration of the NCD and disaster preparedness and framework. And this is also unique to take this opportunity as Copenhagen call to action, also to see how this can take us in the road to preparation for the UNGA this year. In addition to this, I foresee also supporting the national societies last year and developing the health workforce, including volunteers and also staff and medical doctors. That means that just here we cascaded down 3 regional level trainings in Asia, Pacific, Middle East, North Africa, and also in Africa region. In addition, this last year, after the escalation of the conflicts in Palestine, specifically in Gaza, we have been together with the WHO developing an adapted module for training community health workforce in Egypt to support Palestinians who are displaced from Gaza. And also part of the work that we are doing is how we can enhance the tools development. And nowadays, with support with the Danish Red Cross, last year we started the research program to see how we are integrating NCD at time of natural disasters in East Asia, and specifically in Nepal. And we published the peace support handbook that's developed by the Danish Red Cross. I think this is part of how we're also integrating mental health and psychosocial support to people living with NCDs, and particularly type 1 diabetes. I can speak a lot, Kiran, about what we can do and support, but I think that's utilizing this opportunity and specific meeting together as Geneva, as Copenhagen call to action, and what we are, IFRC is doing in this year in terms of preparation for the UNGA, the coming WHA side events, and also the IFRC Global NCD Bootcamp coming this year. We also would like to invite you all to contribute and welcoming you to support and advancing this agenda among us as our stakeholder. So thank you so much, Kiran. Over to you.
Thank you very much, Mahmoud. I think very important to highlight there that when we talk about provision of diabetes care in humanitarian crises, we're not only talking about response, we're very much talking about what health systems can do to prepare or to anticipate and actually to reduce the risk for people living with diabetes. Before we go on to discussion, I just wanted to say that we actually now have the sound back. So I think if we can play the short video that Sana had put up, that would be great. I think in the interest of time, we were actually going to have another round of panel contributions, but to react to what has been said. But I think to make the most of the time we have, I'd like to open up for questions, comments, reflections more broadly to the whole room, but including inviting the panelists to raise questions, reflections to other panelists. So I think the questions can come from anywhere. Apologies, I should have checked with the AV team. There is a roving microphone, is there? Yes, so please put up your hand if you have a question. We do have an online audience, so you will need to speak into the microphone if you have a question or a reflection. So if we do have, please, the first question here, please could you introduce yourself in a few words and then ask your question. And second question in the third row on my right.
Thank you very much. I'm Jean-Claude Mbanya from Cameroon, and I want to thank the panelists for these elaborate presentations. I have two short questions. And the first one is what I've always been trickling my mind, is that we save these children from dying from type 1 diabetes in humanitarian crisis or later, but we allow them to develop diabetes complications and have chronic kidney disease, have chronic complications. My point is, what can we actually do locally in order to sustain the programs that we are developing? And my last question is that, from my experience from the COVID-19 pandemic, how can we set ourselves better to prepare for type 1 diabetes in humanitarian crisis? At IDF, we had a crisis package, contacted the industry for insulin and supplies, and when the humanitarian crisis declared, even during the Gulf of Mexico crisis, we could supply within 24 hours shipment of insulin and diabetes supplies from around the world. But it was predefined, we knew what to do, and we had the data collection and tools. Thank you.
Thank you very much. Could I ask, is your question for any specific panelist, or we decide who's best placed to answer?
I think you decide.
Okay. Thank you. Can we take the second question and then we'll go to some answers?
Thank you very much. I am Suzanne Sapp. I am from Cameroon also. And I want to thank all the panelists for all the discussions. I want to raise something that has been said by Philippa. Thank you for your presentation about the pens. Unfortunately, I saw a picture with Mixstar, and I'm taking care of children and no Mixstar for children. So is it possible, or how can we discuss with different agencies that when we are in a humanitarian crisis or an emergency, we provide more qualitative or insulin of quality more than things that will not help. That's my first, and I want to thank Sana for your presentation about peer support. Should I understand that for all different countries, it's important to have a community of type 1, of people living with type 1 diabetes? Then I totally agree with you. Thank you.
Thank you very much. So I'm going to allocate questions to panelists, but I would also invite, if there is someone from the audience, I can see there are many people here who are well placed to answer some of these questions. So if anyone from the audience would like to answer one of the questions, please put your hand up at that time. But otherwise, I think Dr. Jean-Claude's question, maybe to you, Dr. Getterhun, how can we, even whilst we manage to save children from dying in crisis, what can be done to reduce the development of chronic complications? What is possible to be done locally to sustain that? And then for the question on COVID-19, Mahmoud, would you like to take the question on what can we learn from COVID-19 for humanitarian crisis, particularly about the measures that need to be in place in order to enable response? And then finally, Philippa, would you like to comment on how we can ask agencies to provide insulin of quality rather than things that will not help, from Dr. Suzanne? Thank you.
I think the first question is for me. Actually, it's a very difficult question to answer. This is a question for the audience, all of you. Yeah, first is first, anyways. When a disaster happens, the first thing is to save the lives and then to think about the future management. What I recommend strongly to consider is to have an integrated approach. What we do in the Ethiopian Diabetes Association, I must thank actually our partners to supply insulin, glucometers and everything for all these kids, Life for a Child, CDIC, World Diabetes Foundation and others are working from our side, and the other partners like the WHO, PEMPLAS and Clinton Health Access Initiative all have their contributions to the improvement of diabetes care in Ethiopia. So what's the way forward? I'm sure the greatest worry of us always is what will happen if this integration ends. So the best thing will be to integrate it with the local Ministry of Health and decentralization of type 1 diabetes care, at least in the routine situations. And that's what we are doing. I think the government of Ethiopia has decentralized diabetes care to the periphery, and that will be the best question to take over even these kids enrolled in these donor organizations slowly to the government infrastructure. That is, and what is expected from the donors is to just work on this integration. That integrated approach to the care of type 1 diabetes care will be very important. And in terms of disasters, again, Dr. Mbanyas, it's rather a comment rather than a question. That's a suggestion, because we need emergency strategy, especially for those vulnerable areas. And in this situation, equity should be strongly considered, because when disaster comes, those underprivileged are at risk.
Thank you. Yeah, Mahmoud.
Thank you, Kiran. I think one of the lessons learned from COVID-19, I think that's we need to invest more in health system and infrastructure strengthening. And this is part of what we have been faced across all the world. It's not just only in a specific context. Even developed contexts also have been faced such disruption. So emergency preparedness, one of the most important things. Health workforce capacity building, so that we are ensuring localization as well, and also the service delivery, and also how we are enhancing the community-centric approach from community to community. Because at time of pandemics, it's difficult to reach health facilities. So that's how we are also utilizing the digital platforms as mentioned in the panel. That's Telegram and other platforms could be very useful. So that's strengthening the in building and investing in the community members is one of the most important elements.
Thank you. And maybe I just would like to add a quick question to that. I mean, how many countries maintain registers of people with type 1 diabetes? Because we see that without a register of people needing dialysis, it's virtually very difficult to respond and maintain dialysis for people requiring renal replacement therapy. But many countries now have registers of people with diabetes requiring insulin. What is your experience on that? Is that something that actually all countries should be doing? Is that something that we would really say as a recommendation?
I think this is very important in terms of how we can enhance the capacity. I think in the IADA presentation that Sylvia has been presenting, there's also discrepancy in data collection. And this is very important in how we can standardize not just only the data collection system, but also the standard toolkits for training who are collecting the data, and also how we can enhance the capacity of and working with the member states to support them in developing those kind of system to register people. This year we are going, as I foresee, to publish a global mapping for the NCD across the 191 national societies. And part of the figure that we have been faced, that's unfortunately there is around less than 15 national societies who are working with their member states who are just focusing on NCD and cardiometabolic, not just only including cancer, and but this is also a part of the figure that we need to highlight. Among this, also 10 national societies only who have been doing the monitoring and evaluation and data collection, which is put us in a huge gap in terms of data collection and also the registration. Over to you, Imran.
Stefan, if you want to follow, I also want to very quickly ask Sana to comment on that as well, about how you maintain registers or lists. But Stefan.
Just a very quick point on acute phases and emergency. It's one thing to have registry and to know where is the patient at the beginning, but the patient are moving a lot. If you have the group who have attack in area, they move a lot. So it's also a big challenge to follow the movement of the patient, and like Sana said, the implication of the community to help to follow the movement of the patient, because the registry is a picture at the beginning, but after the patient move a lot. During the crisis in Mali, it was crazy. The patient move every week, every 2 weeks, because they have wars, the group are moving, the war are moving, so the patient are moving a lot. So we need to have this picture at the beginning, but the capacity, to develop the capacity also with the community patient association to follow the movement of the patient.
Sana, please.
So the data that we have, we had initially, some of those children were already in those areas who were affected, and we were able to support them right away because we knew they were in that area and we could approach them right away because we had their telephone numbers, their contact details, their home addresses, everything. But that was not true for the other children who were not already on our insulin support program. And that's where the community came in. The people from that area went to those homes and they tried to get that data. There was, as Stefan is mentioning, there was a lot of movement. So out of these 300 children that we supported during this time, we lost around 122 follow-ups. But having said that, some of them have reached out to us or other community members that we have in place in the areas where they have located and are starting to come back to us for the program. The better integration of the community into the overall information system as well as the service delivery can actually reduce this challenge to a great extent. It was our first time, and we hope that next time we'll have better system in place where we can actually, utilize those community members to track the movement as well and to pass on information and resources as required.
Thank you for, we have a contribution from the third row here, lady in the third row, and I think the point for me that I'm hearing clearly there is that registers are important, but not enough on its own. I think the integration with community support, community resilience is critical here. I don't know if there's anyone from the Philippines in the audience, but the barangay system in Philippines shows that very well, the way that community health workers can keep track of where people are moving to, and together with registers, this is very effective. So we have one comment here, and then a comment in the, I don't know, I think it's the 8th row for me in the middle. So, yeah.
Hi, thank you for this opportunity. I'm Sonali Gunatilaka. I'm from Sri Lanka, and I'm an endocrinologist. This is actually a comment regarding the last COVID pandemic. Our country, apart from the COVID pandemic, was hit by a severe economical crisis. And we didn't have money to purchase insulin. And government, although it is a free healthcare service, could not provide insulin for almost more than 8 months or more than that. So we ran out of insulin. Nobody had insulin. And luckily, because we had this collaboration with Life for a Child program, it just started that year. The type 1 young adults had insulin, but only those who were in the registry that we started that year alone. Others we did not know. We don't know how the mortality is. They did not get insulin. So that's one point I need to highlight. Although we talk of humanitarian setting, yes, that's true. And collaboration with international societies and help economically during that period for insulin supply is very crucial. The children who were saved because of insulin was due to international collaboration that we had during that severe pandemic. And yes, it is important to have registries. We started our own registry recently, and through that we are delivering a lot of support, insulin, other supplies, as well as we are developing peer groups and community support, and that brings up the standards of care as well as their quality of life, even in a normal day-to-day setup, because we were talking about how to prevent the complications following a crisis situation. So I also believe that having a data system is very crucial for all the countries and the communities.
Thank you very much. Excellent point. Can we move on to, so Dr. Benti, and so it's the in the middle section, 3 rows from the back. I want to just say thank you for highlighting that. We do keep saying humanitarian emergencies, but please take that as shorthand for emergencies due to all hazards, because if there's one thing that COVID has taught us is that the confluence of climate-related crisis, pandemic, humanitarian emergencies, mass migration, this affects all countries, and everyone needs to put in place these preparations. Yes, Dr. Bente.
Thank you very much. My name is Dr. Bente Mikkelsen, and I'm currently on the board of WTF. Very happy to be that. First of all, thank you so much for what you're actually doing on the ground. You make it sound simple, but I think we can all understand that it's very far from simple. I really want to know from all of you, because it was mentioned by Mahmoud that 2025 is a very special year. It is a year where we might get all the heads of states and government to actually commit to something that could become real. So what would be, from the panel, the most important ask for governments, but not only governments, but also from the UN at large, industry, philanthropy? I know it's a big question, but you know, they end up with, at the best, one paragraph. So if we are not able to tell them that one thing or few things, it will not happen. So that's very important. And I think one more comment. It is actually horrible that we still have to argue that this is a life-saving commodity. So something is wrong also with the way we are actually advocating. And this was mentioned even by Mike Ryan at the end of the Copenhagen conference last year. Thank you.
Thank you very much. So I think we're going in a couple of minutes. Let's come back to Bente's question, and we'll ask each of the panelists to share their take-home message, thinking ahead to the UN high-level meeting this year. We have time for probably just 2 more questions before we wrap up, and I can see, as usual, 7 hands. Can I ask the lady right at the back, in the green beret, and then I'm sorry, I'm going to ask in the front, the second row here. I think after that, let me see. We probably don't have time for more, but. Yes.
Thank you for that. I know this is a very vibrant audience. I had 2 questions, but I'm going to just, keep it to 1. So my name is Vivian Nabetta with the Sonia Nabetta Foundation, founder and executive director. And I think it's coming after Bente. My first question is for probably everyone on the panel, including my friend Philippa from MSF. So we're in an interesting climate right now with sort of reduction of funding from, let's say, USAID right now. And so I'm wondering how MSF, maybe Red Cross, International Red Cross at the end, their plans to sort of adapt type 1 diabetes care programs in this new climate to ensure continuity of care. I think I'll leave it at that. And I think my next question for MSF would be one-on-one with Philippa. So that's that. Thank you.
So we have a question in the second row here. And then go on, let's have one last question. I just have one. Here? If I ask the microphone, please take your choice. There's many hands up. Maybe the gentleman just next to you, Thank you.
Thank you. I'm from Egypt. I'm Yasmin Hanawi from Egypt. Thank you all for wonderful presentations and insights. As you know, Egypt is, like I could say, a good place for refugees to come. It's a comment rather than a question. It is what we have seen, the importance of community building and group support. We started in our region in Egypt to train advocacy and to train people living with type 1 diabetes, and we started to give training for GPs to help in primary health service, and it was really effective. So I'm always with training advocate and training and empowering these people and empowering general doctors to help and support, because the number is increasing. The number of people living with type 1 diabetes is increasing. And again, I do think numbers are very important. Registries are very important. They are the starting point. Again, training and registries, I think they are very important. Always when it comes to type 1 diabetes, provision of insulin is not enough. We need to give the holistic approach. And this could be done simply and easily by training advocates and training general doctors.
Thank you. Yeah, important comment. So we just have one last question. I'm sorry that there are many more. I would encourage people to both speak to members, to panelists in the breaks, but also to please carry your questions forward into the coming days. I'm sorry there isn't time for more. So one last question.
Thank you. I'm lucky. I'm Professor Vishwajit from Center for Global Health Research, Diabetic Association of Bangladesh. My first question to Sana. Thank you for your nice presentation. In your presentation, you told that you provide insulin to around 300 something, the patients. How do you follow them further? And second, to all the panelists, is there any policy guidance related to the management of the type 1 diabetes during humanitarian crisis? As because we should have the policy guidance for all over the the country, because you do not know when humanitarian crisis come to your country. So is there any guidance or guidelines?
Okay, so we're going to, thank you very much. We're going to move towards the roundup. Now, so the questions that have been raised, Philippa, can you address the question on insulin quality, and also, we didn't forget that, and also the impact of the changing geopolitical situation. Sana, maybe you could comment on how you follow up on patient, people with type 1 diabetes. I'm going to give each of the panelists a chance to speak in turn, to share, as Dr. Bente said, your key message, thinking both towards the UN high-level meeting, but also, as was mentioned early on, one of the outputs of this meeting, which the organizers would like to move towards a call to action, a Copenhagen call to action, which could feed into the UN high-level meeting, but can actually serve other purposes as well. So I think if each of the panelists in turn could make a comment, I'd like to invite, meanwhile, Sylvia back on stage, who will chair the final part of this discussion. And the very last point on guidance, maybe we can discuss that, that can be discussed a little further. WHO has just on the point of publishing operational guideline on an operational manual on NCDs in humanitarian emergencies. This will be released within, it's finalized now, it will be released within days to weeks. So that will be published on the WHO website. So please keep an eye out for that. That is a manual that is mainly aimed at health systems for preparedness and response to all hazards emergencies, and particularly thinking about NCDs, not only diabetes. But Sylvia, in her roundup, maybe you could say a word specifically on diabetes, because I think in terms of initiatives around diabetes guidelines in humanitarian settings. So we'll come back to that point. Can I invite the panelists one by one? Philippa, let's start with you and then go to Sana, and then we'll start at the far end at Mahmoud.
So I'll answer two questions.
Two questions and your key message. And we're going to try to write in shorthand your key messages up on the board. For the online audience, we'll try and put the whiteboard in an area that you can see it, if possible. Yes, please go ahead, Philippa.
Great. So I'll answer Vivian's question first. And I guess, MSF is quite lucky in the sense that we have quite diversified funding. So in fact, the main way MSF will be impacted by these global cuts to funding are seeing the absence of other actors around us. But I think that it's quite clear that type 1 diabetes and NCD care is a critical part of what we do, and that will continue and will strengthen. But I think, the rest of the answer is that providing care with integral community involvement, as has been discussed extensively today, involvement of patients, empowerment of patients at primary healthcare level is a more affordable system of care as well, and more adapted to people where they live. And so this will also be the way we'll have to strengthen moving forward in the shortage of funding gaps. Then to the issue of providing, quality medication. So thank you for that question. I think it's a really important one. And again, I want to come back first to the central role of people living with diabetes. And I think we need to support the empowerment and a strengthened voice of people living with diabetes in order to be able to advocate for the insulins that they need and that are adapted to them, for quality insulins. But then we need to advocate together for cheaper prices for quality insulins. MSF has done costing work that shows that insulin and pens, which are much more feasible to provide, to administer in low resource settings. I mean, I have my team saying, can we provide torches to patients so they can pull up insulin from a vial in the middle of a dark hut in some of our settings. These insulins can be provided profitably by companies that are making billions of dollars from GLP-1s and can quite frankly avoid it for less than $1 a pen. So this is something we need to advocate together. What do people living with diabetes want, and why can that not be provided at affordable prices in combination with injecting supplies and glucose monitoring? Then, of course, what can help with that as well is that we need, guidance and essential medicines lists that support, clear priority choices in terms of insulins that might also simplify the kind of, insulins that are used. And WHO is now working on guidance for pediatric and adult type 1 diabetes, and this can have a really important role to play in supporting systems to choose insulins that I hope will be provided at affordable prices. And then, of course, the last part is training of healthcare workers. You saw Mixtard. We're trying to move away from Mixtard for sure, but in many of the places we work, it's what the healthcare workers are used to, so we need a strong system for training and remotely supporting, if necessary, healthcare workers. But we are managing to do it at primary healthcare level. It just takes organising a system of training and support. So coming back to my final messages, I mean, I have so many, it's really difficult. I think a lot of the messages have come through, the importance of the community, the peer support, prepared supply systems. But I think, reflecting on all the discussion of my panelists and the audience, what struck me is that, in fact, health systems that are able to adapt to humanitarian crises will be, of course, necessary in the new global world with, the climate crisis and increasing pandemics and so on. But also they will be strong health systems in and of themselves. They'll be resilient, they'll be able to be flexible, they'll be person-centered with strong supply systems, that are closer to where people live and engaging the community. So I think a message for member states is that if your health system is set up in a way to be flexible and resilient for health crises, that will give extra strength to your health system, as we confront the new world moving forward.
Thank you very much, Philippa. So, excellent summary. Let's move on to Sana. If you could answer the question and provide your take-home message at the same time. Thank you.
Thank you for your question. I think the 300 that I mentioned there were supported just during the floods period, but later on, these 300 children, and as I said, we lost follow-up with around 120. So the remaining approximately 180 children were included in our existing insulin support program that we run across the country anyway. And the whole intervention was funded by Life for a Child and Insulin for Life, because we wanted to make sure that it's not just children, but also some other, young adults and adults with type 1 who required that support. At that time, where Insulin for Life came in to send us the insulin that we required. We do maintain a follow-up with the funder because we had to, initially, during the flood time, it was very difficult to maintain everything, but we did keep a follow-up on phone numbers, addresses, the locations of the camps they were in, the flood camps they were in, etc. And we kept follow-up with them on telephone calls. The 120 that we have lost, they had lost their phone numbers. They did not have anything to be followed up on. So that's where we have lost those. For me, I think the message that I would really want to give is, again, to the member states, because international collaborations are important. They have played beautifully with us in terms of Insulin for Life support, Life for a Child, DDoC, that has always come in for support. I think the main bulk of the responsibility should be the member states, should be the government itself, because that's where the system really becomes robust, as well as it can scale down to the level where it is needed to scale down. If we build that system in a way where the government holds the accountability and the ground level people, which includes the primary care physicians as well as these communities, to deliver that support, that is how things can actually improve. International collaborations are very important in humanitarian settings, but Some might be age limiting, some might be insulin type limiting, some might be region limiting. We need to make sure that it's actually the government that's taking up responsibility for the country that they're ruling. Yep.
And if I can, just to clarify, particularly enabling then local and other actors to play their part, so the government providing that sort of core platform for multi-sectoral and multi-agency collaboration.
And again, we do a lot of, the collaborations are there. Probably they should actually be trying to strengthen the government to deliver this care in humanitarian settings.
So thank you very much. So I think I said we'd start with Dr. Mahmoud and then move towards this end of the panel for your final take-home messages.
Thank you, Kiran. I think Dr. Binti have been asking for burning questions, but I think that we would like to emphasize that investment on the community health workforce and volunteers, including also volunteers, in terms of capacity building to identify how they can do screening, identifying red flags, so that at time of acute emergency response, they can be a buffer to support the overwhelmed health system, and also how the second part is empowering people living with type 1 diabetes, and specifically including also people living with NCDs, to be an agent for advocacy to support the international organization on this arena.
Thank you. Strictly speaking, that was 2 messages, but we'll let you get away with it because we also are going to invite the audience to critique these messages or to add their own if there are some missing. Dr. Getton.
Yeah, so my take-home message, it may also be true, is to create a resilient health system through integration of international partners and having a clear policy on emergency management, because sometimes handling a disaster may be even beyond the capacity of the individual government or the state. So integrated approach on creating a better resilient health system through international collaboration and local responsibilities, the message that I have.
And would you see that process is led by the Ministry of Health of the country?
Yes, definitely.
Can I just check, so I was talking to you at the same time, did you get it?
Could
Dr. Getton, sorry, I was talking to Sylvia at the same time as you were, apologies. Could you just paraphrase, in short term, just highlight again what your key message?
Yeah, creating a resilient health system through local and international collaboration to handle emergencies.
Thank you. Stefan.
When there is acute crisis or humanitarian crisis in the country, there is an adoption between the country, the UN system and the international head of a humanitarian response plan. And the reality now on the field, we see that in many humanitarian response plans, there is no NCDs or very few things, no diabetes, access to insulin and strips. So my message is for the head of state and the UN system, it's after the summit in September, it will be impossible to have a humanitarian response plan without diabetes, access to insulin, access to strips. Yes, that's my key message, is it's an obligation for me in each humanitarian response plan to have this element in the response plan.
Thank you very much, Stefan. So I'm now going to hand the mic over to Sylvia to lead us through the last part of this discussion, and I'll take the pen. So I think this is a chance, as we think about that call to action, this is a chance to reflect on the messages that the panelists have shared, but please also provide your own, if there are some that are missing, if something else needs to be highlighted on this topic that has not been stated here.
Yeah, from my side also, thank you so much to all of the speakers and for all of the wonderful questions and comments. It's obviously a complicated topic, and it requires an all-hands-on-deck collaborative effort on all of our parts to address this issue. And let me Bente set this up perfectly, actually, because we were hoping, in advance of the UNGA, you know, especially now in our global climate where funding is increasingly challenging, if we really, really have to focus our asks to the UN member states, what do we want to come out of that meeting? What are our key asks and opportunities for us as a global community? And I think some of these points that were just raised, you probably can't read any of it, but it's more for us to work through now in the next 10 minutes before we end to say, you know, where as a global community, you know, where do we want to be and how can we ensure that humanitarian settings are included in what comes out of that meeting? And so a few of the things that have been listed here around, you know, health system strengthening, resilience building, particularly engaging the local communities, the people living with diabetes, the community health workers, build and the disaster response preparedness. So being prepared is so crucial. Another one on member states and governments needing to play an increasingly more prominent, a key role in all of this and helping create a framework within their countries for all the local actors and international actors to come together. Another capacity building of community healthcare workers. I think that kind of ties in with the first point. And very importantly, empowering people living with diabetes in advocacy and making their voices, you know, heard on a global scale. How do we do that well? And making sure that we stay connected to what they actually need in the field. In real time, you know, as Sana was saying, that's tremendously important, and as people move. And then find an integrated approach to creating a resilient system, so that's also something that was mentioned earlier. So there's a bit of a theme here, and the need for a comprehensive humanitarian response plan that includes diabetes. It just has to, it can't be an add-on thought, or, you know, it must be integrated in the entire system. So I'm just going to open the floor to any of the panelists, or if one of you want to add in terms of a key message or two, perhaps to highlight specifically at the UN, and ideally also potentially for the Copenhagen call to action. That would be great. Philippa, go ahead.
Yeah, sorry, just to add quickly, I can't actually see the board, but from what you said and what we've discussed, I think just a key point that I see missing in terms of a very concrete ask is supply. You know, as Stefan said very, you know, concretely, you know, in the acute emergency, it's just about getting the supply to patients, and again, the bundle of supply, but this would be a really concrete ask. We need to have preparation for supply systems that can be adapted. You need to be able to give multiple month dispensing to people living with diabetes and other NCDs, and supply systems that can adapt as well in terms of how medications are distributed and who distributes them in an emergency.
Any other comments or questions? Okay, a lot of comments. How about right here, Dr. Abdul Basit, right?
Abdul Basit from Pakistan. I'm very grateful to the organizers for organizing this meeting. I understand the emergency of this UN declaration. My humble suggestion is that amongst the NCDs, please take type 1 diabetes as a special cater of fish, because they can't live for 5 or 8 days in crisis without supplies. So something to highlight, especially for type 1 diabetes. Thank you.
Absolutely.
Insulin in an emergency is an emergency.
Yes.
I don't. How about you, right behind?
Thank you so much. I agree. Insulin in an emergency is an emergency, but the supplies, I think, it's the real emergency, because if you have insulin and you have no idea what your sugar is and whether it's down and going down, or down and going up, or up and going up, you are in big trouble. And I think too often we don't talk enough about that, the ability to monitor the insulin. Because in an emergency, recently in Ghana, we had issues with flooding, and as I watched the donations come in, every time I watched the donations, my heart just sank. It was all rice, tinned tomatoes, I mean, non-perishable goods, of course. And I'm just imagining you have diabetes and all you have is white rice, 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 rice. So I think supplies, insulin, yes, supplies. And it's been mentioned about mixed-diet. The problem is not the pre-mixed insulin, it's the regimen. So for children with type 1 diabetes, you want to be able, them to be able to do basal bolus. But what is basal bolus even when you actually cannot adjust? So yes, I agree. I'm a diabetologist. I'm a family physician. I work on the front line. It is important for children to be able to achieve tight control. However, if you give them pre-mixed insulin, that is not possible. So you save their life and then we are dealing with complication. But even if we get to the situation, the stage where we're giving them the cheapest of insulin, NPH, you can't find it. Mm-hmm. And you give them NPH with regular insulin, and they are not able to adjust the dosing because they have no idea how much carbs is in that rice they are eating. They don't understand it. They can't even check it. So it is, for me, way beyond insulin. Yeah. And yes, even the society where they are in, are they going to inject that insulin when they're in school? Or they're going to be stigmatized? So they would rather not, let's just do the premix. I do it in the home before I go to school. I come back, I do it in the house. So it is beyond insulin, and we need to get that message out. Thank you so much.
No, I absolutely agree. I mean, it goes far beyond insulin. I think, probably we can all agree in an immediate emergency, you have to get insulin in there and the supplies with which to inject it and monitor in the immediate. But then, of course, I think we've been talking about this quite a lot, is about disaster preparedness, being prepared to know how much insulin to take or not if you can't access food, having the supply. I mean, it just goes on and on and on, right? So I hear you completely, and I agree. How about right back here? And also, if you can please introduce yourself. Sorry, I forgot to mention that, so we know your name and where you're from. Yeah.
Thank you very much. This is again Jean-Claude Mbanya. I think I mentioned COVID-19 when I first intervened. After COVID-19, the G7 countries set out a disaster preparedness. Why can we not integrate type 1 diabetes in this disaster preparedness package as we go into the United Nations? But more importantly, there is also a disaster wing of the United Nations. So we have to include type 1 diabetes into it, but tagging also the disaster and type 1 diabetes emergencies in low middle income countries. That would provide the funding, because most of what we have said here, the question would be who would fund it, how would we fund it? But I'm putting the G7, because if they adopt it, then we're going to have not only the funding, but also integrate in an existing disaster preparedness. Thank you.
Yeah. Yeah, integrating, I think that word has come up a lot as well. Very, very critical, absolutely. Okay, who has on? How about right over here, you, sir? Okay, yeah, go ahead. And go.
Thank you so much. Thank you for excellent panel. Thank you for all the participant input. I'm Adelat Kakunze from Africa CDC. So we've been talking about different stakeholders, community, patients. Somebody talk about the role for government, Ministry of Health, which is for me crucial, because we are looking at how do we strengthen our primary health care. It's an issue of UHC, but also health security, because we are looking at preparing for emergencies, humanitarian crises. But if there's one thing that we've learned, the continent have learned from COVID-19, is to rely on outside the continent supply. what are we talking about? Local production, ensuring that we have sustainable supply for those life-saving product. I think this is important. I mean, it starts from where we've now seen with the high prevalence how this is widening the gap between the supply and the demand. How do we tackle that? I haven't heard anything about addressing this critical issue on availability and affordability and really driving the local production, particularly in Africa. Thank you.
Yeah, thank you so much. And we do have to wrap up here in 2 minutes. So if you can please make your intervention very brief, and then we'll summarize for the day.
Thank you. Hello, I'm Zoran Stojkovski from Union of Associations of People with Diabetes of Macedonia, North Macedonia. Great input of all of you. I must say that talking about humanitarian crisis, but widely speaking, it reminded me on having similar crisis when you have corrupted government or corrupted health systems. Because talking about the system, actually we lack, let's say 2 years ago, for 11 months, we haven't had opportunity to get free of charge these items for measuring blood sugar. And at the end, we ended up with the, it's rubbish anyway. We ended up with the no-name device. I don't know, the name is Tyson. We contacted, from the union, we contacted the producer in Taiwan. They said that in the moment we get, for 2 years, they were not producing it. We have no idea how government health system actually got this. When you compare with the, let's say, the better one, actually they measure 10, sometimes 5, 10 more units, more than, and then for 11 months we were out of needles, out of devices, out of everything, which is completely similar. I cannot say that it's like humanitarian when it's floods and other wars and other crises. But believe me, I think that especially for one of the things connected for preparation of this important meeting, having these types of input, especially representing patients, organizations, in probably most of the countries in development, these deals between pharmaco companies, local or even international sometimes, is absolutely giving us as a type 1 people with diabetes aside from real quality care.
Yeah, no, thank you for bringing that up. That's obviously very challenging issue to address, and we'll definitely take it into consideration. In the interest of time now, because we do need to wrap up, I'll have Kieran just briefly summarize these 5 points. We will go back and work on it and put it into some more cohesive format that we'll send to the organizers for their consideration.
Thank you, Sylvia. I'll do this very briefly. I think, thank you for the comments that were raised. I think they, a number of them align with comments that have come up in the panel discussion and enrich that discussion. I think supply has been a central point there. And when we talk about supply, we're not only talking about insulin, but we're talking about the bundle. We are talking about supply of appropriate insulins and appropriate equipment. We're also talking about local production. the importance of local production for life-sustaining products. And there was a strong advocacy message around this as well. I think the reminder that supply disruption is not only due to hazards, natural hazards, humanitarian emergencies, can also be due to characteristics of governmental characteristics. It can actually be due to supply disruption due to private company, the Aeroflot ceasing to function for a period and Kyrgyzstan receiving no insulin. So the point here again is that all countries need to consider supply. I think a second important point is about the narrative and the sensitization around diabetes, the exceptional nature of type 1 diabetes, but also the fact that there is work to do on sensitization, on destigmatizing. This is a complex problem. It's not only supply, it's actually effective care for type 1 diabetes requires essentially collaboration and working together across sectors in society. So there's an important advocacy point relating to the narrative. And the final thing I think that was highlighted from the floor is the point about disaster preparedness packages and health security frameworks. And this is probably a strong point for the high-level meeting, that we're talking about integration of diabetes at national level, yes, in disaster management frameworks and policies at national level, but also when we're talking about international cooperation on health security, diabetes needs to be flagged here. This discussion, I would love this discussion to go on throughout the 3 days, but I know I'm not the person setting the agenda, but please do approach panelists for further discussion, and I look forward to meeting many of you over the coming days. And thank you, Sylvia, for hosting a fascinating session. And thank you to the panelists. Sorry, did I say that? And of course to the organizers, please.
Yes, please. Thank you very much to IADA, Kieran, and Sylvia for organizing this first side event of today, and in fact the first side event and session of our entire conference. I don't think we could have wished for a better start. You started out by connecting the NCD high-level global technical meeting we had in Copenhagen a year ago to this side event. The meeting in Copenhagen was a relatively broad agenda and has taken different streams subsequently. I believe we saw a paper released on cancer recently. I think, Kieran, you were involved in the paper extracting that track. Maybe we should also consider having a stream extract of diabetes and maybe even type 1 diabetes. This event, this week, we are discussing type 1 diabetes very specifically, but of course it has many lines to different aspects of health and healthcare response. Thank you again also to the panelists, and with that, I think another round of applause for the IADA.